Hey guys, back again for part three. Thank you for watching part one and part two. We're going to go into how to connect up the monitor, how to zero the monitor, talk a little bit about the phlebostatic access, what that's really called, things of that nature, so that way you feel more comfortable with the art line. So part one, part two, part three, you will easily be able to go back and look at them. Got Helen over here. She is the expert on art line. She's been wonderful in this interview. We're going to go ahead and do some access points. So where are we?
Okay, so we have connected to our patient, okay, and this is just going to be our saline bag. We're going to now have to connect to our monitor. So what that is doctor is probably going to ask you to hand him the like the sterile extension tubing. He'll say flush. You'll put the tubing, the flush the tubing. All right, and then he's going to hook it up into the catheter itself, and you're going to have your setup ready. So this is our patient, okay? And the next thing you're going to do is, okay, is it in the under the skin? Is it in the artery? Where is it? Okay. So this is where what's going to show up on your monitor screen. So to hook, each transducer setup comes with a cord. How you set this up in your holder, this is that stiff tubing that I talked about. Make sure that goes up. However way you remember that is certainly fine with me. I have no objection to any of that. I had two daughters that really, really liked Barbie when they were little. So this always reminds me of Barbie's ponytail. So Barbie's ponytail works for you. It works for you because that's always what was helpful to me. Again, the stiff part is what's going to go to your patient. And like I tell my Orients when we're talking about Life Pack 20 and telemetry class or critical care class, healthcare equipment fits together pretty easily today. All right. Because so if you have to take your ice pick and try and ram something in, newsflash, you're probably doing it wrong. So if you notice when I put that together, it fit together nice and easy. My arrow was to the top, and you probably heard a small click. Okay. All right. So that click is really what's important. All right. And now we're ready to go. When you look what happened on our monitor, now all of a sudden I got a red waveform. But look where it's at. It's just above the zero line. How do you know your patient's blood pressure is accurate? Well, a couple reasons. You have to, first of all, what they call zero it. And I could zero it way up here. I could zero it way down there. What's the perfect spot? The perfect spot is actually what they call the phlebostatic axis. And if that corresponds to the fourth intercostal space, mid-axillary line. So right around the armpit. Okay, so if you forget phlebo anything, just remember we should be around the armpit someplace and you will be good to go. So it should be even with our mannequin here, our patient. This looks pretty doggone good. If my blood pressure, my transducer is too high, I'm probably going to get lower blood pressures. If my transducer tubing would be a little too low, like let's say way down here, I probably would get higher blood pressure. So it's really important where you put it. Some ICUs will actually tape it right to the chest wall. Tape is a double-edged sword because you can run into skin problems with that. So here's your yellow cap. That's that dead ender cap we talked about in part one. How do you zero? So zeroing is we're going to go off to the patient. Okay, so we're going to go up towards Barbie's ponytail or to our stiff tubing and open it to air. All right, so we're going to open that stopcock up. Then we're going to come here and we are going to hit zero all our pressures. Or sometimes you'll see a little, depending on what monitor you're using, you might see zero. On our GE monitors, we can open the A line and we can say zero our line, which is really good. You can zero that as well. All right, so we can get out of there. Look what magically happened though when I zeroed. Number one, I have disconnected. Two, I got 0/0. Okay, so that's the right thing you want to see. And my line went from just above the zero line to zero. All right, all right. The scale is really important too because we're 100, 200. So this is your millimeters of mercury. For something like a CVP, you might only go as far as 25, 30, 40. Okay, but for a blood pressure, you're going to need at least 200. So you can adjust the scale accordingly. Okay, all right. So now I got to put this back together. So I'm just going to put my cap on. All right, and then I'm going to put it back together. One neat thing with the arterial line, which might be helpful to you as you're new to arterial lines, is this. Everything that you see, every point where you're connecting, every connection point should be parallel. So parallel, okay, parallel, parallel. If I see something like this, what's going to happen is now I'm going to go crazy because I'm not getting a waveform. So obviously something like that is a no-no. All right, so I'm just going to give my patient a little bit of a blood pressure. All right, so we've zeroed, we're at our phlebostatic axis, and this is what you should see, some type of a waveform, and that's how we know we're in the right spot. All right, especially sometimes when we're doing central lines in the neck. If we dip an artery, we'll see an arterial waveform in the neck, which thankfully doesn't happen too often, but I've seen it and it's not pretty. All right, so everything looks good. Our bag is pumped up to 300 millimeters of mercury. My blood pressure is showing on the screen, and now you got a very good invasive blood pressure, which is going to give you every 5 seconds, it's going to change. That'll help you titrate pressors or whatever you need to do, fluid management, whatever. One thing that is kind of cool is when I have my arterial waveform right underneath my cardiac rhythm, it's just kind of an observation that I've made through the years because I've been dealing with this for a long time. I can see my cardiac waveform, and let's say everything's blipping along, my sinus rhythm and everything, and then I see a PVC. And if you look underneath the arterial line, okay, remember electricity stimulates mechanics. All right, sometimes you'll see a nice waveform go up and down. Then you'll see maybe a waveform of a lower amplitude and the blood pressure goes down a little bit. You know if that person's perfusing or not, that PVC is perfusing the system. So that's just an interesting little thing that I've noticed through the years, which is kind of cool. All right. So zeroing is important. If you are moving your patient around, okay, what's really important to know is, you may zero more than once, during the course of your shift. You push your patient's head up a little bit to eat or to do a procedure, to put an NG tube in, whatever you're going to do. You're going to turn them from side to side. You can zero that as much as you want, and just as long as you want to make sure that your readings are accurate. And that's the best way that's going to do that. Keep it lined up with the armpit or the phlebostatic axis. Okay, so let's talk a little bit about waveforms, okay? So I'm going to do handy dandy drawing because I do a lot of drawing in classes, okay, critical care classes and things like that. So this is that was kind of a makeshift one because I was squeezing a saline bag, but this is how a normal waveform actually kind of looks. And when you take a look at this, you know why art school did not call me back. But actually, what we did over there was not too bad. But you have a swoop up top here, that's your systolic blood pressure. Then you come down a little bit, okay, and you have what they call a little notch there. That's your dicrotic notch. So if you think back to the cardiac cycle, that's the closure of your aortic valve. So all of a sudden, your left ventricle ejected into the aorta, your aortic valve closed, your left ventricle is now going into diastole and relaxing, and now down here, you got a diastolic blood pressure. So that's normally how it should look. It's a little wonky and AFib, but other than that, but this is a very good picture, picturesque of a waveform. Systole, a closure of the dicrotic notch, diastole. And then you'll be able to see where everything corresponds regularly or not.
Yeah, so like they're saying, the zero is here, so that's perfect. That actually looks amazing.
The look looks pretty good.
Yeah.
So when you put one in, it's a little bit easier to see, but that's just the picture of a waveform. The CVP looks a little bit different, but the arterial line waveform is pretty straightforward and it's pretty cut and dry. What else? So that's just something to keep an eye on. Like I said, it might be a little bit lower amplitude if you're having an arrhythmia of some kind. You'll see it acting, you'll see it go a little faster. Will it go a little bit faster? Whenever not everybody's heart rate in the emergency department is a perfect 70, 75, right? You'll have an A line waveform should correspond with every QRS complex that you have. So you have a person in sinus tachycardia with a heart rate of 148. This will be clipping along just like your EKG will. So that's kind of cool. Care of an arterial line and things that you should know. First of all, the dressing. Hopefully we'll have a bio patch over it when doc puts it in. We too have arterial line insertion kits. Everything the doc needs should be in there. He or she is responsible for their sharps. So don't get on that bandwagon that you're going to take the needles out for them. Nope. That was their kit. That's their problem. All right. Next thing is we want to make sure that you're looking at neurovascular status. Remember, this isn't an artery. I think one quick way to kind of save yourself in documentation is to put the pulse ox here. Okay, so that's easy. It's non-invasive. if you're getting a 98% reading on your pulse ox, hands getting perfused despite the fact that you have an arterial line in there, okay? Capillary refill. And on the inpatient side, ER, maybe you could explore this, like with your flow sheets, there's a vital signs complex that has all that information in their arterial line and what your mean arterial pressure is, etc. So that's kind of a good thing. You can zero it. If it's calibrated, that means that we zeroed it, we calibrated it, zeroed and calibrated like what I just did. Okay, you can do that as many times as you need to for your shift. In addition, these kind of stay in our policy is we're going to change this tubing every 96 hours. It may or may not, last that long. If think about it, I got an IV catheter because there's not a needle in there, it's just a little catheter that's whipping back and forth. After 2-3 days, just like an IV, 4 days in there, you'll start whipping, your waveform will start looking a little dampened. And by dampened, I mean something like this. You won't see that crisp dichrotic notch, you'll see something like this. And it's like, it looks like the last rose of summer. It's like, okay, that's kind of how it looks. And it's like, I'm dying, So that's just a couple of things. So just keep an eye on your waveform. You should be documenting a waveform at least every 8 hours to make sure that everything is copacetic and good. An A-line waveform should draw back real easy if you're going to be drawing blood. If you're getting air in there, and I was a recovery room nurse, I thought, I'd come into an overnight patient. We didn't have an ICU bed, and I had an arterial line. I had a hard time drawing from it. That art line's not going to last very long. We either need a new one or to keep it out completely. So that may be a decision, a bedside decision, game time decision that you'll have to make. All right. Thanks.
All right, guys. I appreciate your effort of watching this. If you have any questions, we've done 3 parts to the art line. You can fast forward, rewind, look at different parts if you want to. This first video is, the first video that we did was going to talk a little bit more about, the start of it. The second video was more about the blood, the blood from the line. The third video was waveforms. So I'm going to label them as such. All right, thanks.